Okay.
Bismillahirrahmanirrahim. I would like to begin our live academic session today that will be presented by Dr. Gulnaz, which will be on assessing a patient of vocal cord paralysis and its management. I would also like to welcome Dr. Khurshid Alam, who is a consultant of ENT working at Doctor's Hospital, and we would love to hear from him regarding the topic. Thank you. Basically, on assessing a patient of vocal cord paralysis.
Assalamu alaikum. My topic of presentation is assessing a patient of vocal cord paralysis and its management. Vocal cord paralysis is a complex condition that can significantly impact a patient's quality of life. This presentation will provide an overview of evaluation and treatment options available for patients with vocal cord paralysis. What is vocal cord paralysis? It's actually result from immobility of the true vocal cord, resulting from disruption of motor innervation to the laryngeal musculature. Meanwhile, vocal cord paralysis result from partial disruption of motor innervation. Now we will discuss about how to approach a patient with vocal cord paralysis. Unilateral cases account for 75% of cases, more common on left-sided and predominantly occur in males. 60% of the cases can be diagnosed by taking proper history and detailed examination, so our detailed medical and surgical history is particularly important. Most of the time, patient will present with the symptoms like voice changes, which can range from hoarseness of voice to aphonia. Complete the ODPAR of symptoms. Ask the patient about onset, duration, progression, aggravating factor, relieving factor, and associated symptoms. Patient with bilateral vocal cord paralysis will present with stridor or aspiration. Associated symptoms include vocal fatigue, neck pain, aspiration, weak ineffective cough, vocal abuse, stridor, GERD, dysphagia. Okay. Ask the patient about neurological symptoms like tremors, dysarthria, any limb weakness. Rule out pulmonary symptoms like cough, hemoptysis. Ask about infection or any trauma, smoking and occupational exposures. Systemic illness like rheumatoid arthritis should also be ruled out. Past medical and surgical history is also very important. Likewise, family history and comorbidity. Next, examination. Examination should include inspection of the neck to see laryngeal framework or any swelling or scar mark, and palpation of the neck for lymphadenopathy or any thyroid enlargement. Check laryngeal crepitus. Assess the voice of the patient. Assess its quality, loudness, and pitch. Cranial examination should also be done to rule out any intracranial lesion. Ideal, which can easily performed in OPD, by which we can assess maximum adduction and abduction of vocal cords via e-sweep test. However, direct visual examination of larynx with FOL provides valuable information with respect to possible etiology of vocal cord paralysis. General physical examination is also important, like if clubbing is present, it means there is an underlying cause is bronchogenic carcinoma. Systemic examination like CVS, GIT, chest examination should be done to rule out underlying etiologies. Next, investigation and imaging. It includes chest X-ray, which rule out any lung lesions, In case of unidentified etiology, CT skull base to diaphragm is recommended. If you are suspecting any cranial lesions, MRI brain is recommended. Modified barium swallow is done in cases of aspiration. Video stroboscopy is done to see the structure and movements of vocal cord. Laryngeal electromyography is an ideal test to assess the neural integrity of the larynx. Here is a video stroboscopy of the normal female vocal cords. Here you can see subtle mucosal motions of the vocal cords and vocal height, which is not as much appreciable on F4 and 70-degree examination. Laryngeal electromyography. It helps in determining the type and timing of surgical intervention and done between 1 to 6 months. They differentiate mechanical fixation. Here is a graph of EMG. If it's normal, it means the underlying cause is joint fixation. If there is fibrillation on EMG graph, it means denervation is going on and surgery must be delayed until denervation is complete. Prognosis will be bad in this case. If there are polyphasic waves on EMG, it means re-innervation is going on and prognosis will be good. What are differential diagnoses of vocal cord paralysis? It includes mechanical vocal cord immobility, which can be due to cricoarytenoid joint fixation or displacement, infiltration by cancer, or posterior glottic stenosis. These are vocal cord position during respiration and phonation in normal person and unilateral paralysis and in bilateral paralysis. Vocal cord paralysis are divided into two types on the basis of muscles, that is abductor paralysis and adductor paralysis, which can be unilateral and bilateral. Here is an endoscopic video of vocal cords. See the video and tell what pathologies you are suspecting. Yes, it's unilateral right-sided abductor paralysis. As you can see, vocal cord is lying is in median position and not moving during respiration and phonation. Now we will discuss about unilateral abductor paralysis. In this case, paralyzed cord will lie in median or para-median position. It occurs due to unilateral recurrent laryngeal palsy, which can occur in malignancy of neck, most commonly in thyroid CA and thyroid surgeries, trauma, and can be idiopathic. Most of the time, patient will present with complaint of dysphonia, that is weak breathy-wise, breathlessness with exertion, no aspiration or airway compromise. Management. It depends on patient characteristics such as age, occupation, and patient preferences will ultimately guide the management plan. Once an underlying neoplastic process has been definitely ruled out, expectant treatment may be indicated. Most of the time, spontaneous recovery will occur. However, if there is no aspiration, limited voice user, neuroparexia, that is limited stretching of nerves, and favorable electromyography, then observation and speech therapy is recommended for 6 to 12 months. Injection augmentation. It is done in cases where there is high degree of vocal disability or high vocal demand, good or indeterminate functional prognosis, and small glottic gap, that is 2 mm to 3 mm, and there is no posterior glottic gap. In this case, we do medialization of vocal cords using injection of inert materials. Here is the procedure. First injection is injected at the level of posterolateral angle of middle third of vocal cord, 2.5 mm lateral to the vocal cord margins. Second injection is given at anterolateral angle till both vocal cords meet. What are materials used in injection augmentation? These include Teflon, fat, collagen, hyaluronic acid, calcium hydroxyapatite gel, which is also known as Reddy's Weiss. Results of recent multi-institutional trial demonstrate excellent result at 12 months follow-up and showed that persistent medialization after calcium hydroxyapatite injection may be present up to 2 years or more. What are complications of injection augmentation? If we do over injection, it will compromise airway. If under injection, complaints will be unresolved. migration of material can occur. If superficial injection, it will cause stiffness of vocal cord. Medialization thyroplasty is done in cases where there is a high degree of vocal disability, poor functional prognosis, and large glottic gap greater than 3 mm and posterior glottic gap. In this case, medialization of vocal cord done using blocks of inert material. Before doing medialization thyroplasty, manual compression test is done. Pressure is applied at the level of vocal cords. If Y is improved, do medialization thyroplasty, and if there is no improvement, do arytenoid adduction. Here is a diagram showing thyroplasty type 1. It involves Here is a diagram showing thyroplasty type 1. It involves displacing and stabilizing a small rectangular cartilaginous window in thyroid lamina at the level of vocal cords, pushing the soft tissue medially with using material, celestic material like titanium, Gore-Tex, and hydroxyapatite. Complications include airway compromise and implant extrusion. Here is another treatment option, which is laryngeal re-innervation, which is done by using nerves like ansa cervicalis and hypoglossal nerve in sections of vagus or recurrent laryngeal nerve during thyroidectomy, but it takes months to show result. Here is a diagram showing neuropathy between ansa cervicalis, which supplies sternohyoid, and recurrent laryngeal nerve. Now we will discuss about bilateral abductor paralysis. In this case, both vocal cords will lie in medial or paramedial position, and lesions of bilateral recurrent laryngeal nerve occur. Most commonly occur in thyroid surgeries and pregnancy, CA esophagus. Bilateral vocal cord paralysis present with symptoms of airway compromise that range from being mild to more commonly dyspnea and stridor. Voice quality is often mildly affected as the paralyzed vocal cord tend to assume their natural position during phonation. Management of bilateral abductor paralysis. While voice is the predominant issue in the cases of unilateral vocal cord paralysis, airway is the primary concern in cases of bilateral vocal cord paralysis. Tracheostomy required in cases of significant airway compromise. Other treatment options include transverse chordotomy, arytenoidectomy, muscle re-innervation, thyroplasty type 2 to lateralize the vocal cord. Here is an endoscopic video of a patient presented in our OPD with bilateral abductor paralysis, post-thyroidectomy, which was done from young. As in picture, we can see that both vocal cords are adducted and they are not able to open during respiration. Tracheostomy was done to secure the airway, and then we did laser chordotomy in this patient. Here is a video showing laser chordotomy. Same. Same. नहीं चल रही थी दूसरी हाँ ये चलती है मैंने सर्च किया हुआ इसमें अच्छा in laser chordotomy, soft tissue at the junction of membranous cords and vocal process of arytenosis is excised laterally with laser. The patient is intubated with 5 or 5.5 laser save ETT. CO2 laser precautions are implemented, including placing of saline soaked laser in subglottis to prevent disruption of ETT cuff. The application of topical mitomycin C to the wound for 5 minutes is an optional adjunctive treatment in an attempt to decrease fibroblast formation and scar tissue at the operative site. Complications of laser chordectomy include voice changes, granuloma formation, contractures of arytenoids, laser-related fire, inter-arytenoid scar formation. The use of systemic corticosteroids and systemic antibiotics generally are recommended in each of the described endoscopic procedures. Topical fibrin glue may decrease scarring and hasten to improve healing at surgical site. Now we will discuss about adductor paralysis. Unilateral adductor paralysis. In this case, flaccid paralysis of vocal cord will occur and they will lie in lateral position. Lesions of vagus are both recurrent laryngeal nerve and spheral laryngeal nerve can occur. Causes are thyroid surgeries, lesions of nucleus ambiguous, intracranial lesions involving jugular foramen or parapharyngeal space. Patient will present with weak husky voice and aspiration. Management. It depends on etiology. With proper speech therapy, the healthy cord may compensate the loss of function of paralyzed vocal cord. In uncompensated cases, injection augmentation is done using Teflon paste lateral to paralyzed cord. No, medialization, laryngoplasty, and arytenoid adduction is the preferred procedure. एंड पे दिखा देंगे ये छूट ली थी इसको एंड पे डिस्कस कर लेंगे हाँ एंड पे कर लेंगे Now we will discuss about bilateral adductor paralysis. In this case, both vocal cords will lie in lateral position. It's rare and occurs in CNS diseases, skull base or upper neck lesions. Patient will present with loss of voice like aphonia, aspiration, and inability to cough. It's occur in lesions of vagal, both recurrent laryngeal and spheral laryngeal nerve. Management. As there is glottic insufficiency due to both adductor paralysis, our main priority will be to save airway. Tracheostomy is essential to remove pulmonary secretion and inhaled material. Feeding tracheostomy or gastrostomy will prevent aspiration and maintain nutrition. Surgeries for chronic aspiration include tracheoesophageal diversion, epiglottic flap laryngeal clear, subperitoneal cricodectomy, narrow field laryngectomy. Laryngectomy is done in cases where cause is progressive and irreversible and speech is unserviceable. Laryngectomy will prevent repeated aspiration and lung infection. To preserve voice, injection, augmentation, and thyroplasty type 1 is recommended. Recent advances in treatment of laryngeal paralysis. It includes laryngeal pressing done in patients suffering from bilateral vocal cord paralysis. In this case, electrodes is placed into each posterior cricoarytenoid muscles, which cause maximum adduction and abduction of vocal cords. The electrode is connected to external pacing device that is surgically fixed under the chest wall in a similar way to cardiac pacemaker. Thank you. Thank you for your attention. Sir, क्योंकि left-sided recurrent laryngeal nerve take longer route than right-sided laryngeal nerve, so that's why that's more prone to injuries. जी sir.
So, what do you think? So, the patient presented to you is all patient complaint of change of voice.
जी sir.
How do you proceed?
Sir, like I will proceed with same like I have already told. We will complete the OD para of symptoms like voice changes, onset, duration, progression, any aggravating factor or relieving factor, and then associated symptoms will help me to make out my diagnosis and underlying pathology which is causing hoarseness of voice, which includes CNS symptoms, pulmonary symptoms, or any thyroid surgery, any history of smoking, occupational exposure to any like toxins, and any complaints of stridor, aspiration.
Screaming. आप कैसे फील करते हैं आपके पास वॉइस so
जी सर. Most likely thyroidectomy.
Hypertonic are more common on that.
जी sir.
Idiopathic are more common. Hypertonic, why? Because
Superficial है इधर.
its length is small. It's less resistant to stress. So even with retraction, you can damage the prostate. So hypertonic is more common on the right side, otherwise it's not common. So yes, in history, you know, of the posters, but it's eating and drinking is very strange.
जी sir. Stress.
And this is a surgery on the back.
Sorry. बच गए थे। ठीक है।
So, yeah, history is important. Any history of infection.
Heart room.
आमिर भाई ये आप
So
अपने
you
कैमरे
can
को आवाज
always classify it into inflammatory, traumatic, idiopathic, neoplastic, neurological. So if you have the differential in your mind, then how they take accordingly.
जी sir.
If they have a neopathic neurological condition, bacterial condition, or anything like that, Parkinson, and in children like kids with uninitiated so, anything else in history you would like to add?
Is it important, like if the patient has husky voice, breathy voice? So, is it helpful when how to proceed? Like if the patient has lost the pitch, it means they are suspected the patient has severe laryngeal paralysis. Or some breathy voice.
Children having a paralysis, normally they would only complain, they won't complain of stress. Really would complain.
The pitch is lost.
But they would say when we are singing or when we are talking in a high tone, and that is the reason.
Right.
And we know the pathophysiology of that also because the thyroid muscle is supplied by the
External.
that's the motor power.
Yes sir.
So if that is paralyzed, it will lose the tone of the this thing. And it's highly noticeable that condition. And aspiration is very important because it's very laryngeal. The internal part is yeah, that's the sensory part. The sensory part you have more aspiration. And so that comes into yeah. And mostly they would have a history of I mean most of the vocal cord I really see people with aspiration. Very few of them will come with that. Most of them will come with hoarseness, especially the idiopathic. But with post-traumatic, yes, they have sometimes they have difficulty in eating and drinking.
Regarding the movement of the vocal cords, so I have in my mind. Number one, the main supply of larynx is supplied by the vagus nerve. Okay, vagus has two branches: recurrent and superior laryngeal. Superior laryngeal has two branches: internal and external. Internal, that is penetrating in the thyroid membrane, is sensory. Sensory to supraglottis and hypothalamus. All the muscles of larynx are supplied by the recurrent laryngeal nerve, except hypothalamus. It is supplied by the external branch of superior laryngeal. Number one, there is only one abductor, that is the posterior cricoid minded. And there is a one important muscle that tense the vocal cord. Tense means it tighten the vocal cord, that is the cricoid, which is supplied by the superior laryngeal, external branch, superior laryngeal. And there is one muscle that loses the tension, that is the vocalis muscle. So don't mismingle the posterior cricoretinoid. It is abductor. So when there is a injury, actual understanding the position of vocal cords or laryngeal paralysis, we have very good concept of median, paramedian, cadaveric, and abductor position. And I think this position cannot be understood with the 70 degrees flow.
Can I add to the
Yes.
to that? Even the recurrent laryngeal branch has got two branches,
Right.
anterior and posterior. So the anterior one is supplied the pelvis, thyroid and area.
Right.
Rest are supplied by the posterior, like PCA and CA. They are supplied by the posterior. So that is the reason when the patient is intubated, because of the pressure on the anterior branch, because it's anterior there, they get sometimes temporary, sometimes permanent. And yeah, it's very complicated. Why category? I think if superior laryngeal nerve and recurrent laryngeal both are paralyzed, it's mostly on the category.
Right.
Both are paralyzed. If superior laryngeal is intact and recurrent is paralyzed, then it would come into a bit of a median, paramedian. But that is not the.
So, sir, is 70 degrees because majority of ENT surgeons are doing now 70 degrees. So, I never did 70 degree, but in my OPD, we have only 70 degree, but we have five that is placed in our theater. So, what do you think? 70 degree is okay to assess the actual position of the vocal cords?
I think it's quite mandatory to do a endoscopy. And when we do, I mean, now we have come to examination. We finished things to that. So in examination, the most important part is the fiber endoscopy, which I would see the three things. I mean, one is the movement of the folds. Okay. And second is I would ask the patient to sniff. You can ask, do you know what sniff does? Anybody? Yeah. No. Anybody? Why would you ask the patient to sniff? I mean, have you guys seen the
Yes, sir.
somebody they call them.
Yes.
Just somebody was what would they do? They would bring a bottle in front of the nose and ask them to sniff. It was not the medicine, it was the sniffing, because sniffing activates the PC. So it causes the abduction. So if anybody is choking or having a laryngeal spasm, ask the patient to sniff. So you look at the abduction, and sometimes the hidden part of vocal cord paralysis, you look at the vocal cord, everything looks normal. And the patient, you just ask them to sniff. And when you ask them to sniff, you see there would not be an abduction of one vocal cord. You can catch vocal cord, hidden vocal cord paralysis with this. When you ask them. So this is a very important part of it. Ask them to say E. And other thing you will see is because of the compensation, the patient will be using the supraglottic area more. So these things you can't do with 70 degree. You ask the patient to say, you ask the patient to say E. Another very important thing, even in history when you're doing is the maximum phonation time. That's why it just needs 30 seconds. Maximum phonation time is a very important. Just to, if a patient comes and ask them to say, and in females it's from 15 to 25 seconds. In males it's 25 to 35 seconds. If it's less than that, we call it the MP. Another very important part in history is the VHI. Most of I even don't do it, but I think you all should just get it from the internet. Why it's handicap index. Just get it from the internet and get it printed and ask the students to just fill it up. I mean, ask the attendant help, because we have to translate it into Urdu. One thing we have to do, I think. And VHI is very helpful to monitor the patient progress. And third is history. It's very important to involve the speech pathologist. You should have, as a laryngologist, you should have a good relationship with the speech pathologist, because to diagnose is very important, very helpful. If we do a fiberoptic laryngoscopy and you assess the patient, the speech pathologist is with you. In most of the developed countries now, they have voice clinics now. Anybody with a voice goes to the voice clinic, and there is a speech pathologist, there is a laryngologist, sometimes there is a neurologist as well. and then they assess the patient. So this is recording about that. If there is any questions?
Sir, back to the fiber optic laryngoscopy. So when you do the fiber optic laryngoscopy, you put the scope, and what maneuver you ask the patient? One, you have said that one is sniff,
Yeah.
then say E,
Yeah.
then phonate, those numbers.
Yeah, you count it down.
10.
With the counting, you see the supraglottic area. I mean, there is a classification. I mean, it's called MTP 1, 2, 3. I mean, on something. MTP 1 is when the vocal folds do not come close to each other. You know, that's in functional dyspnea and other condition, nodules and thing. And MTP2 is when like false chords are projecting.
Right.
So that's MTP2. So MTP3 is when there is anterior posterior squeeze.
Right.
And MTP4 is when the total squeeze. So MTP4 shows compensation. And you'll see one or two. If there is more than one, there is always some kind of paralysis. You'll see MTP2 and 3 and 4. So it means there's a vocal cord paralysis. But that's a bit on the higher end. For the graduation level, I would say, okay, just keep it simple in a way. Just ask them to say E, sniff, and phonation, like 1, 2, 3. Or ask them, it's very easy to ask them, okay, Alhamdulillah, suna de, kalma suna de. Everybody knows that, So, I mean, it's easy for that to check that. And another thing I do for aspiration is we call it as a feast. I've done few of that, not a lot, but it's another subject. I think feast is functional endoscopic evaluation of swallow. That is the patient who is having aspiration, and for the speech pathologist, it's very helpful to find out which level do they have in this area. But I think that goes completely on that area. So anything else?
Sir, for these are all postgrad. So there are the two situations. One situation is a laryngeal paralysis.
Yeah.
And other situation is the fixation of the vocal. Like if there is an involvement of the vocal cord due to some disease process, then we can say that is a cord is immobile or cord is fixed.
Yeah.
So that is due to some disease process, while laryngeal paralysis is a different.
That's a neurological.
Yes, that due to disease process like tumor, then you can say the vocal cord is fixed. So, but if the cause is some neurological disease, then you can say laryngeal paralysis. That is the paralysis, not fixation. Fixation is due to either direct involvement of the tumor or adjacent tumor has involved the joint. That is called the fixation. So,
the only way to differentiate is laryngeal EMG. But I don't know. I don't have a laryngeal EMG. Myself, that is a difficult part for people. Like, do you have a laryngeal EMG? I mean, the reason, Pakistan is lacking behind is because of
gadgets.
poverty.
Yeah.
Because we can't afford to have a laryngoscope, we can't afford to have a laryngeal EMG. And because they are very important part, I mean, how can you differentiate between the laryngeal paralysis and the frequent fixation? The EMG is the only way out. So if we don't have so the only way is you either give anesthesia to the patient who might have endoscopy and palpate the rectal region and see whether it's fixed or not.
Now we discuss one by one each situation. Okay. Now suppose because almost all causes are the same.
Yeah.
Causes the laryngeal, that is a tumor, infection, stroke, blah blah blah. Almost causes are similar. So we will discuss one by one. Suppose if a patient has right recurrent laryngeal nerve paralysis. So what are the consequences? What is the position of the vocal? Because we are, after taking the history, we will do the examination and we can identify only with the position of the vocal cord. Then we can say he has right vocal cord recurrent So what is the situation?
So if there is a right recurrent laryngeal paralysis and vocal cord will lie in median or paraplegic position due to adaptive function of vocal cord. And position like patient will present with symptoms of weak breathing, and there will be no history of respiration or any strident, but patient will tell in history about like past surgical history is very important. If there is a past surgical history, then there is no need of extensive intervention, like investigation.
So we are talking what is the situation of the vocal cord.
So
Vocal cord will be
in median or paraplegic.
median or paralytic.
Yes, sir.
So you can say there are the two situations. One is a partial injury, there is a complete injury. Okay. If there is a partial injury, the vocal cords may be in the paralytic.
But does it make any difference whether it's a paramedian or a median position? Just to check.
Yeah.
And it doesn't make any difference in management.
No, there is no difference.
Yeah, I mean, the difficult thing, the most difficult thing to find is the paralysis.
Yeah.
Now, how would you find a vocal cord paralysis? Does anybody here know that? I mean, if you want to look at the paralysis, if you know something, then only you can look at it. So if you do a fiber optic laryngoscopy, there are two things you have to do. One is the interarytenoid tube. The tube will be looking at that side. Okay. And that you looks at the superior laryngeal palsy, it will look at that side, and the vocal cord on that paralysis will be more exposed as compared to the other side. So these are the two things you will see when you're doing fiber optic. You look at the, I mean, when I found about it, then only I started diagnosing, because a patient comes to you with hoarseness, and you look at the you do a fiber optic and everything is normal. So I mean, you just tell the it's very frustrating for the patient. So once if you can find the paralysis, then you can send the patient for speech therapy, and then even therapy, whatever you can go for that, you know. So it's very important to diagnose vocal cord paralysis.
So you can detect only with a fiber optic.
Fiber optic,
But without with a 70-degree, you can't detect.
70-degree is just to see if it is yes or no.
Yeah. Yes, no, or if there is some tumor, you can say that this patient can be intubated or not, and that's it.
Yeah.
No other information you can get. Second thing which I'm adding, like suppose Dr. Gulnaz was asking me yesterday, sir, the recurrent laryngeal nerve is supply both adductor and abductor.
मुझे सर ने एक बात बताई ना, anterior and posterior ये तो सब मेरा point है.
बाकी
सर मेरा ये प्रश्न था कि जैसे हम कह रहे हैं adductor paralysis है और recurrent laryngeal हमारी जो उसका paralysis है, तो अगर उसका हो रहा है तो दोनों जो है ना हमारी को paralysis होती है. तो why we are seeing this adductor paralysis? तो वो ये कि anterior branch होती है. जी सर.
जवाब मिल गया आपको?
जी सर.
ये फायदा है ना एक्सपर्ट बंदे का. अच्छा, so now if the patient has superior laryngeal paralysis, like after we are doing the most common situation is the thyroid surgery. So you tie the nerve along with the vessel. So if there is a superior laryngeal, it causes only one problem: aspiration and loss of pitch, and that's it. The patient have complain of cough on taking liquids.
Aspiration also, if the sometimes internal is spared in pandemic.
Yeah.
So only the tone, that's fine.
I think so. This is also self-limping. It will
never take that.
मोस्टली सिंगल से फील होती है.
क्योंकि तो पिच खत्म हो जाती है. पिच खत्म हो जाएगी, आवाज को खींच नहीं सकेगा, और उसमें आम बंदा समटाइम डिटेक्ट भी नहीं कर पाता. So if the patient has, well, the next situation is if the patient has bilateral recurrent laryngeal nerve injury, then what will be the situation of the cords?
Sir, both oral cords will be in medial position and patient will be that operation will be normal, but both of the cords.
लेकिन इसमें both posterior cricoretinoid, एक्चुअल आप ये समझे कि जब भी इसका फंक्शन जाएगा ना तो कॉर्ड्स में ऐसे आ जाएगा, ऐसे आ जाएगा। और जो सीमंस थ्योरी है, व्हाट इज सीमंस थ्योरी के एबडक्टर पहले जाएंगे उनके फंक्शन, एबडक्टर के बाद तो जब भी कॉर्ड की नर्व साइड ट्रांसलेक्ट होगी तो उसने बाय नेचर उसने ऐसे आ जाना। अब उसने ऐसे नहीं हो पाना, एबडक्टर एक है, ठीक है, तो कॉर्ड ऐसे मिड लाइन में आ जाएगी। लेकिन एक ऐसी सिचुएशन भी होती है जिसमें कॉर्ड अवे हो जाते हैं, व्हाट इज दैट? कैडावेरिक। वो क्या, वो फिर क्या है जो डिफरेंट अगर दोनों होता है तो ये क्या है, हाई वेगल लीजन हो गया उसका, हाई वेगल लीजन हो गया, उसने स्पीरल एंजल को भी ले लिया, उसने रिकरेंट को भी ले लिया। तो अब जब वो रिकरेंट भी गई, स्पीरल रेंजल भी गई, तो क्या हो गया, पेशेंट को उसकी सेंसरी भी गई, उसकी मोटर भी गई, ऐसे हो गए। जब ऐसे कॉर्ड हो गए, ये वो है जिसमें कह गए अब ट्रैकेओस्टमी कर दे, ये कर दे, वो कर दे, इंट्रैक्टेबल एस्पिरेशंस पेशेंट को डेवलप होना शुरू हो जाती है। सो मेरा ख्याल है सर कि आइसोलेटेड स्पीरल रेंजल इंजरी इज लेस कॉमन,
It's mostly acrogenetic.
most all spinal region.
Idiopathic, yeah, I'm not sure idiopathic.
It's mostly heterogeneous.
Yeah.
Zone का एक क्वेश्चन पूछा है रिजवान ने, okay, how can we manage paradoxical vocal cord, a vocal fold motion?
That's a very interesting. हमारे टाइम पे एक कुछ मेडिसिन रजिस्ट्री के नाम से दैट वाज paradoxical. I think I'm not I can't recall now, but इसका कुछ अभी चेंज हो गया phenomenon because what is happening is on reduction it is adapting, मतलब वो false chords use करना शुरू हो जाती है इसके paradoxical movement में ना, and I'm not really sure really कि इसका क्या तो I haven't seen really a lot of them. Again, at initial stages when I saw them, we used to give them nectar at that time, and it used to work very well. Or this paradoxical.
अच्छा, मैं इसमें मैं कुछ ऐड करूं, व्हाट इज पैराडॉक्सिकल formation? We see some in some situation the patient came to us and say, so during talking what about that, can't breathe, there is a choking episode. This is called paradoxical vocal formation. When the vocal abduct it gets stuck and now the glottis is closed, so the लाल पीला हो जाएगा, फिर वो पीछे
I think ये जो है ना बात है paradoxical, अभी ये obsolete हो गया in a way कि I think it was spasmodic dysphonia.
Okay.
क्योंकि उस वक्त spasmodic dysphonia was not in picture, so I think nowadays they take it as क्योंकि उसमें ही हो रहा है, पर ये बता रहे हैं कि वो मतलब है कि start एक तो वो false chord बहुत ज़्यादा यूज करना शुरू कर देते हैं और हम type 2 कहते हैं कि और पैराडॉक्सिकल में भी ये होता है कि वो false chord को ज़्यादा यूज कर रहा है और उसमें फिर ये कि हम बोटॉक्स लगाते हैं सिचुएशन में बोटॉक्स और उसको some get मतलब उससे होता है कि वो you have to keep doing it, but most of the spasmodic dysphonia उसमें तो हमें every 6 months to 8 months we have to keep injecting.
So paradoxical vocal motion disease is not diagnosed as spasmodic dysphonia. So spasmodic dysphonia is of two types. One is a adductor. So how can we differentiate on the patient presentation? What is adductor?
Because 80% or 90% are adductor spasmodic. If an adductor spasmodic का मतलब है कि when they are talking, they adduct more.
Right.
And even then, like you say, whereas adductor, when they start talking, they vocal cord adduct. If there are few words, they cannot like H, in like a doctor, especially during the vowels, they will attack more hard, And so the doctor spasmodic dysphonia sound, the diagnosis is your ears. And then you come, patient will come, and in the doctor spasmodic, actually, I think
Yeah.
Interesting, because if I start talking about that, they go in that direction.
So, our answer to the paradoxical
Yes, sir.
question is a cut short. This disease is replaced not with spasmodic dysphonia. That's a different. So, those are my question is, suppose we see a quite significant number of patients. A patient, can old age patient, he has right or left vocal cord paralysis, and we do everything, CT, history, everything is normal. No, what would be the next step if all the investigations are normal?
One thing in differential diagnosis you should keep in mind is press valve and press valve is the old aging muscle wasting of the it's very common. You see the bowing line, when they're talking. So because there's a wasting of muscle because of the age. Press by larynges.
Press valve, yes. But I am talking only one vocal cord.
Okay, you got one vocal cord in the management would be the same way. I mean, again, would be taking the same history and sending the patient to the
If
speech
all
therapy.
everything is normal, we do all tests.
Speech therapy is
Speech therapy, or how much we have to wait for further interventions? So the cord is that lies.
It depends on the patient. If the patient is very distressed, then obviously we wait for 6 months. I mean, nowadays, the latest things people are doing is they don't wait.
Right.
They just inject like temporary things you described, hyaluronic acid or hydroxylapatite is very good. It is, the problem with these are they are very expensive. I checked it out at around 7-8 years back. It was €350. It comes with the whole set with that hydroxylapatite, and you just go there and inject. Just take 5 minutes to inject it as a patient walks away. And anyone with vocal cord paralysis comes to you. People, there is a school of thought. They say you should wait for 6 to 12 months. But there are other studies which show that if you inject them, and if hyaluronic acid is one, for hyaluronic acid stays for 3-4 months. But hydroxylapatite or fat is very good. But the thing about the fat is you have to inject it a bit more. You need a special piston or injection for that to inject fat. Just like microlaryngoscopy.
Peyronie's ridge. Yes.
You have that?
I think so, but we have not used. It is available.
Yeah, but
the Peyronie's ridge.
it's very simple. You just crush just take a fat.
Make it liquid and
Make it liquid and just inject it and
that is absorbed.
Yeah. It stays for 1 year, and the new studies show because the fat has stem cells, and because of the stem cells, they say it helps in regrowth of nerves and things there. So it is the best choice actually. It's better.
So, is there any role of PRP?
No.
It's gaining much popularity these days for different. As we check the PRP.
So we have another question. In vocal cord paralysis, how can we make swallowing assessment?
Swallowing, one is swallow, or you can say video fluoroscopy is idea. Video fluoroscopy and radio fluoroscopy is the same thing. If you don't have a video fluoroscopy, you go to the radiologist and just tell them, or tell even the picture tender, but if having a barium swallow, just make a video. So that is one thing. Second, I just mentioned about fees. Functional endoscopic evaluation of swallow respiration is a beautiful test because it will tell you that what is it the oral part of it not squeezing. We do fees in neurological cases just to find out the severity of the thing. So, yeah, I mean, these are the things that you just give them initially ice. When you bring fish, what you do is you take food color and we start with water, ice, then water, then yogurt. Just put a lot of the food color in yogurt. And there are different signs you see. If there is a pudding in a piriform fossa, you just ask the patient to swallow. And you see there is a pudding, it means that there is aspiration.
So, are there any diseases that we can only locate in fish and that are usually missed in video fluoroscopy or barium
No,
source?
speech is just harmful to speech. I mean, you just give them an information that please focus on these areas. Facial area, oral area, laryngeal area, just follow patients. The palate is not closing completely or whatever. So you just give them.
No, sir.
Any question here?
हाँ डॉक्स बताएं। अच्छा सर ये बताइए कि सपोज अब हमारे पास जब एक पेशेंट को bilateral abductor they call the abductor like stroke patient. So what
They're having aspiration.
yeah, having aspiration. Initially, the neurologist or we put the nasogastric tube. So, what must be the optimal time for waiting that the movement will come back?
It's a very, very difficult situation. Where I would one of the workshop where they couldn't find a real good answer to that because the only way out is even you do tracheostomy, but they say if you do tracheostomy, then the road it affects the swallow. I mean, the swallow, I mean, the larynx is so it will make the aspiration worse, but at least your lungs are protected. So, I mean, if it depends on how much chest infection patients are getting. If the patient is getting recurrent chest infection, then not recovery. And
Have you any experience of epiglottopaxy or laryngeal closure procedures? Is it really helpful?
But as Dr. just showed on the presentation that in laryngeal people or to close the glottis, to stitch the glottis altogether. So these are the things which are very good to see.
Because one of my patients, he has stroke, and after that, he have bilateral adductor paralysis. Cords are abducted, and he is on nasogastric for the last 3 months. So now I am convinced that you must have some PEG, or you must have tracheostomy.
Yeah.
So what is a good option?
I think first option would be to patient lungs is the most important part. If lungs are protected, and then be able to swallow something by mouth, even with aspiration, the lungs would say, or you know, you have some taste to something, and if you cannot, then you might need to just impact.
So what is your experience regarding the novel time of the surgical procedure for the rehabilitation like middleization? So what you do if the vocal cord is abducted? What procedure you do for the middleization?
Yeah, I mean, my advice if I do paralysis with
Fabulous.
now, paralysis with people do is silastic cord. Most of the people like it. I like cortex because it's more flexible, and while I'm doing it, I can ask the patient by keep talking, and I can sometimes correct it, sometimes remove a little bit, sometimes put in it. The only problem with putting vortex is when you're making a tunnel, you should not make a very high or low. It should be at the very just lateral to the bones. Because if you make a high tunnel, then the water goes into the subglottic. The patient will have a squeaky voice. I had one. And having squeaky voice, and the other very good advantage of Vortex is you can move it at time. So you can remove the scholastic block, but they're quite difficult to draw. What do you use normally?
I have very little experience.
See, what I've done is it's very expensive and it's very cheap if you want it. If you buy cotton, it's very expensive. But if you have friends like vascular surgeons, they the pieces they use for aorta, that one piece of aorta I took from India, and I'm using it. I can use it on 10 things, and that's for free. Because he's anyway he's going to throw it out, and sometimes you might keep it. So, and you just cut it. They've got nice grooves in it. Just cut it and keep putting it in, keep putting it in. It's very simple. And you just have the local anesthesia of that. It's very rewarding surgery.
So in some situation, patient has vocal cord paralysis and he has some serious tunnel lymphadenopathy.
Yeah.
So we send the patient to radiologist to CT guided FNAC. It's very difficult to get the CT guided FNAC, and patient remain gathered stones between ENT, radiologist, pulmonologist.
I think
The best solution.
Because the etiology is you can manage the. I will say you treat the patient. The patient having voice aspiration, we manage that part, right? But the rest will be tailored to the
Just diagnose and go to the radiologist or pulmonologist depending on.
I've seen patients with tuberculosis presenting very hoarseness and
Yeah, you should keep in mind. If there's a pulmonary tuberculosis, that can also cause this thing. X-ray chest is a good, very good investigation. CT, yeah, if you have more concern, because the concept is that the region has to be big enough because of the blood paralysis. So it should be seen on X-ray.
we'll take TB first.
And you're talking about a tuberculosis. Yeah, I mean, they treat the TB and again you treat the patient also. I mean, if the patient is having aspiration, then why did you send the patient to speech therapy? And at the same time, you start It's simple actually. You know what? How we do theraplasty is standard done in local, what you call local anesthesia. Patient is away, and you put a camera, just fiber optic laryngoscopy, and put that hospital monitor. So just before doing anything, I would put a needle and just you see the movement on the vocal cord. I would always confirm because I would always confirm the vocal cord proceeding. I mean, you make a window, and after the window, you just put a little needle. Don't go through it, just very gently. Just feel it, and you see the movement of the vocal cord. You see the needle moving downwards, then you just move it up. Just move it, and once you know, okay, this is the area where the vocal cord is, you stay lateral to the vocal cord, and just put vortex in it, and keep talking with the patient. I mean, I would do it with the IP sedation. And then just tell them to say, okay, say something. Are you happy with the voice? No, or okay, just put a little bit more. Sometimes this becomes squeaky, then you take it out. So that's how I do it. And it's nice you can tune it up. It's a very rewarding thing.
So when we're talking about permanent injection, what is your experience regarding migration? Because very much permanent injection.
Yeah, I don't have much experience in this because I don't know for some reason patients are agree and I don't have a proper gadget. Never did a proper gadget. I inject just like injecting botox in the foot. The same thing, you just put lateral to the thyroid. Teflon is almost gone now because the problem with Teflon was, granulation. I've seen many of Teflon in myself. And then you cannot reverse that. If you overdo it, you can't do it. Anything for you start. So the best thing is this hydroxyapatite or hydrochloric acid or fat or junk food or these things are still better choice.
So this is also the treatment of press laryngitis.
Yeah.
This is the excellent treatment.
This
Laryngitis.
is injection.
The strength of the cord is lost.
Yeah.
And they do not keep the midline problem. So you inject your cord with the midlines and the voice for the output.
But you have to inject.
See, I mean, if you inject fat, I mean, it's on a saal aram se nikal jata hai. And if somebody comes to is 80 years old, that's sorry. I mean, why would you do thyroidoscopy on that or something? And most of them I've seen they're not keen. They say, oh, Professor, अगर कोई बीमारी नहीं है, कोई जानने नहीं पड़ रहा. So they don't bother to do. Voice, where I've got experience, काफी लोगों को मतलब जैसे आपको नहीं आपको you just want to make sure that we answer yes is correct.
मैं ख्याल जो इंश्योरेंस ओरिएंटेड कंट्रीज हैं वहाँ पे ये पॉपुलर है. इसमें पैसे किसी और में देने.
पैसे किसी और को देने हैं तो
वहाँ पे काफी डॉक्टर प्रोसीजर है.
now to direct cost up here and nobody wants to spend money on that. Or bilateral vocal cord पे yes मतलब जिस तरह अगर check है मतलब sort out भी I think you do sort out the and then if it is due to the fixation of periphery or to bilateral cord, that's one thing you have to see.
So have you experience of Christmas future lateralization?
Lateralization, yeah, but I don't have an experience. Yeah, but I know. I think it's good to have it. Just going above and below.
I have done a case at doctor's hospital.
I see.
But the problem is that when you put the
And do you just stitch it or you do cordotomy and then stitch?
no. So this patient I treated at doctor's hospital. Pediatric ward की जो nurse है हमारी इधर.
अच्छा.
उसकी thyroidectomy हुई तो cord उसके हो गए.
अच्छा.
So I was reluctant to do her cordotomy.
अच्छा.
तो मैंने ना उसके लिए स्टिच लगाया. यहाँ पे इसकी थोड़ी सी expose करके.
I see.
तो प्रोटीन से
Going well. The other thing which I've read is that they do cordotomy and not a very extensive cordotomy, but you do cordotomy and then you put a stitch and you, with the button you just stitch it for 2 weeks, leave it there for 2 weeks and wait for it to fibroze. So, and then you remove it after 2 weeks. It will move back a little bit, but it's supposed to fibrose and scar laterally.
Dr. Gulnaz has a video of this patient. This patient was operated at thyroidectomy. So but she remained on tracheostomy 2-3 years.
I see.
2 years or 3 years?
2 years.
2 years.
I see.
So I did cordotomy.
I see.
And after that I took this. I decannulated the patient, close the trachea and close the bone, and that's it. The patient remained all right. So, in short, so what is the take-home message regarding the management of patient having laryngeal paralysis as a resident? What they do? They are sitting in a heavy OPD. So what are the important tips and tricks that they don't miss the serious patients and they must reach to the ultimate diagnosis? What is the take-home message?
See, I mean, complete examination of the laryngoscopy, so the availability of laryngoscopy, and with that load of patients you have, I mean, sterilization of the laryngoscope, it's not an easy thing to do, and I mean, I'm sure both of you must be using just a mirror.
Yeah, you do the ideal.
You do the ideal. So I mean, with the ideal, all you can see is you just say E, and then you see, okay, he's got vocal cord paralysis, yes, or no. And it's a very difficult situation to assess. But still, at least it's better than nothing. I mean, obviously, you have to do ideal. You do ideal or laryngoscope to exclude any tumor, any nodules, any benign condition, and if you diagnose vocal cord paralysis, then you book him for laryngoscope, complete examination, and after that send them for X-ray chest and blood test. Really. CRT and CBC, I think that way. And if there is a history of tuberculosis, and look at the neurological side of the history is very important. I think in our specialty, 80% of the case, before even you say anything to examine the patient, you should know what's going on. You should have no difference. Just by listening, I mean, 80% of every patient you should know before examination. You should make sure 80% that what this patient has. And then you just do just confirm what it's good, things like that. And yeah, and the best thing is involve your seniors. Ask for help. If you don't know, get to the professor. You know, it's very important. Don't be shy of it. Never be shy in asking your professor because they are there to help you. If you're shy about it and you say, oh, okay, let's see. Anything. I mean, once I remember I was doing a round and a senior registrar asked me a question. He asked me, he was post-mastered patient. He said, if this is a post-mastered patient, you come after a few hours and the patient of palsy, what would you do? And I was a medical officer, very keen. I said, I'll call my registrar. So he started laughing, you know. I said, so I didn't know, because at least I was safe, I was not wrong. I said, I'll call my registrar, I'll call my senior registrar, I'll call my professor, you know. Then he just put a hand on my shoulder and said, okay, let's imagine you are in a desert. Nobody is there. What will you do? Then I said, I'll move the back. So it's that is the only way to engage your senior. Even among you, you have got registrars and senior registrars and assistant, associate, professors. So you have to do it yourself. You have to learn things yourself and read.
Yes. There's another question. What is the management for conversion disorder?
What's that?
Functional, which functional dysphonia?
It's very difficult to treat that. It's a patient of functional dysphonia.
Speech pathologist. And if you have psychiatric evaluation is very important. There are two things. One is psychiatric evaluation, second is speech pathology. I mean, and the third thing is you have to exclude any other organic pathology.
That is very.
Dr. Ilyas is saying that you've done a great job and it was a much needed talk. It would be more beneficial if you can arrange a live demonstration.
Live demonstration of what?
Talking about surgery.
Surgery, therapy,
Okay, so we will request to Dr. Khushi.
Yes, sir, we can lend our education. Yes, yes.
So Dr. Yas, we are forwarding to this delegate, inshallah, next time. So I think so we must upgrade ourselves. So I have not, I don't think so Dr. Khushi has done ideal. I don't think so.
It's been a long time.
It's been a long time. So I have no idea.
Especially after COVID,
Yeah.
Well, before COVID, we used some ideas of that, but after COVID.
70 has gained much popularity last 3 years, but this is not a different diagnostic for the energy pathology. So we must encourage all the consultants, they must use the fire rocket. That is an ideal case. Because with holding the tongue and you can't ask the patient to phonate, he can do only 2 movements. Inhale and exhale, and that's it. So you can see only the mobility of the vocal cords or any obvious, and that's it.
We cannot slip also.
Yeah, of course.
Slipping is also.
That's it. Thank you so much, sir. In a short notice में आपने ये 12 मतलब कि हमारे से 12-14 लोग engage हो जाते हैं, फायर से भी और सारे, तो अगर ग्रेजुअली हम अपने